It's been very exciting to hear how much interest there is in stroke, and especially on World Stroke Day. It's a great honor. So I'm going to be speaking to you about new approaches, novel approaches to Icad. My disclosures and positions are shown here. I'm going to provide
có một cái outline về những cái gì chúng tôi sẽ nói. Chúng tôi nói về không những
standpoint. Speak a little bit about how we define intracranial atherosclerotic disease, or Icad, to look at the imaging features, how we look at the flow patterns, hypoperfusion and collateral flow, and then to think about how we're using imaging in our clinical trials. So I often speak a lot about precision medicine, and you may have heard about precision medicine starting from genomics, because this is where precision medicine first started. Now, almost 20 years ago, at the time of the Human Genome Project, the availability, the capacity to do genomic analysis, the concept was born that each individual patient with a different profile or a different genomic profile may be slightly different than the next patient. But this idea has expanded in terms of precision medicine to other diagnostic methods other than genomics to think about patients. And definitely, I don't think as much about genomics, but definitely about imaging and how imaging can be used to define how one patient is different than the next. So even when a patient presents with an acute ischemic stroke or a stroke of any kind, even if their clinical syndrome may seem quite similar, the patterns on imaging may be quite different. Subtle differences that may tell us how one patient may respond to a treatment differently than the next. In precision medicine, there's this concept of theranostics, which is a combination of therapeutics and diagnostics, where the two are merged together in close combination. Some people refer to this as an integrated or combined approach to diagnostics and therapeutics, with the point or the objective to really figure out which is the right treatment or therapeutic approach for a specific diagnostic pattern. In this case, speaking about imaging in Icad, what the infarct pattern looks like, what the flow downstream looks like, and what the specific mechanism of the stroke is in that Icad case. So in general, precision medicine in the stroke field is about matching, in this case, with Icad and stroke, matching a specific therapy to that patient and to try and tweak or perfect the underlying mechanism to reduce the risk of recurrent stroke. So intracranial atherosclerotic disease is very important in not just brain health, but in terms of cerebrovascular health. We've heard a lot about cardiovascular health, cardiac health for many, many years now. And only in the last several years, probably maybe about 5 years or so, have we heard more about brain health. And as a neurovascular or stroke person, I'm much more concerned about anything that's neurovascular and stroke related and vascular health or cerebrovascular health. Imaging tells us a lot about what happens over time. And I'll demonstrate how in intracranial atherosclerotic disease, how we're using imaging to tell us how patients do over time, over a longer time period with chronic disease like Icad. So why study Icad? This question comes up all the time. The textbooks in the United States will tell you that Icad is not very common as a cause of stroke. And much like I've said since I went to medical school, I don't believe everything you read in the textbooks. And even the epidemiology, as Craig showed you earlier, is changed nowadays with imaging. And what imaging starts to reveal more and more is that Icad is the most common cause of stroke around the world. It's incredibly common. And even in the United States, it's much more common than we think. And there's an underdiagnosis of intracranial atherosclerotic disease. But even more so because the way we ascertain or measure the occurrence of Icad has traditionally been when people complain of symptoms, when they have a stroke event. And at least in the United States, there's a difference between one person and the next in terms of when you complain of symptoms. And some people complain a lot and others don't complain at all. And people may have cognitive impairment or cognitive impairment that's associated with the recurrent, relatively silent events, but they may not have a stroke. And what imaging does is it provides a secondary diagnostic approach in parallel to the clinical complaints, where we can track what happens over time. So we see the imaging evolution of lesions of strokes due to Icad when we start to image patients. Despite all this, and the rising importance of cognition and cognitive impairment in a disease such as Icad is the downside, or the limitation is that everybody said for a while now that there are no proven treatments in Icad. And this causes a big problem because it really removes the motivation of physicians, providers, or anybody else to do anything differently. Some people will say that because there's no proven treatments, whether medically or interventionally, that we shouldn't be doing anything from a diagnostic approach to treat these patients. But we have done a lot of trials over the years. We've done the WASA trial with Mark Chimowitz, as well as the Sampras trial, and we've had limited findings over the years. By comparison, acute ischemic stroke trials seem relatively easy. In the setting of acute ischemic stroke, the emergency situation will drive the go, no-go decision about whether we should do something or not. Unfortunately, in Icad, we have more time. And that's a difficulty because over time, when we have more time available, it makes the decisions much more difficult. But one of the limitations has been in Icad is that we deal with the very specific definitions. Stenosis, a narrowing in a vessel in a specific area in an artery in the brain. The imaging features that we look at are much more expansive beyond that, beyond a stenosis. We've also limited things in terms of our indications for endovascular therapy, as you've just noticed in terms of endovascular therapy and the talks before me. So there's a lot of questions that have been limited by the definitions that we've imposed. We see this as well. We see asymptomatic disease. Asymptomatic disease is asymptomatic because people don't complain of the symptoms. But people come in and they have these types of lesions where there may be a high-grade stenosis of the right internal carotid artery. And once we do imaging, we see that there's good collateral flow and actually underlying disease. In terms of perfusion imaging and the flow patterns, there are milder delays, but the definitions that we've used have been very restrictive. So we look for severe perfusion delay, but this is not what occurs in stenosis. So what we've learned about imaging in terms of acute ischemic stroke doesn't apply in the perfusion delays in Icad. The measures are very different. The measures are milder delays that we see, as shown here in the left hemisphere, where the CBV and the CBF is preserved. So in addition, the way we've characterized the events in terms of clinical events at baseline, in addition to the fact of how we handle TIAs, the type of TIA and how we consider those presentations is limited. And it's limited our approach to the disease in general. So as I mentioned, we really rely heavily on reporting of clinical events. We have limited serial evaluation because we don't follow patients over time and bring them back to image and see what happens over time. A lot of the times this isn't done. And we don't look at the sequelae such as cognition or what happens in terms of cognitive impairment in the brain over time, although that is changing recently. Most of the time we tell patients to come back once they have a clinical stroke or symptoms of a stroke. And we don't do neurocognitive testing and follow-up. So much is focused on this, a focal stenosis and narrowing in a specific arterial segment of the brain. Now, this is very common with what we see in systemic atherosclerosis with coronary disease. And this shouldn't be a surprise because the two are due to the same underlying condition of atherosclerosis. But what is surprising is why a systemic disorder, something that affects the whole body, causes a lesion or an abnormality in one segment of an artery in the brain. And this should be a surprise to us. And a lot of people don't take a step back and think about why is it so focal. But there's a very simple explanation for this, and that's because it's driven by flow. And as I can describe to you, atherosclerotic disease, Icad, or intracranial atherosclerotic stenosis, the narrowing of the vessel, only occurs at specific regions because of the flow in those segments. It happens just beyond bifurcations in vessels. And the pattern of disease is actually not random. It happens only on specific walls of the vessel. All right, it's not a concentric or a symmetric narrowing of the vessel that occurs. So there's a very specific pattern, and it's all driven by flow. And that becomes important in terms of not just what we do in terms of the short-term treatment, but perhaps what we do in terms of long-term treatment of Icad as well. So diffuse Icad does exist, and we don't recognize it. This, when we talk about, the trials that have been done, we've always looked for, those that are at highest risk of stroke, where there's really severe stenosis. But the problem with that is that when you start to look for more and more severe stenosis, a focal severe stenosis, you ignore other types of disease. You ignore mild disease. So 50 to 69% narrowing of a vessel is not been considered in most trials of Icad. We have considered it, and you can definitely see it very commonly. And strokes do occur in that milder range. But even more importantly, diffuse disease exists. This is a patient that has a perfusion delay and has actually Icad not in one vessel, but in every single principal arterial territory to the brain. And the thing that I find amazing about this is that because it's because it's non-focal and diffuse narrowing of the vessels, such a patient doesn't have a focal stenosis and would be told that they don't have disease. They don't have atherosclerotic disease. The other manifestation of Icad that exists is this. We see dolichoectasia, vertebrobasilar dolichoectasia. In the United States, this is not seen as atherosclerosis. As a matter of fact, patients that have these types of results are told that there's no problem with the large vessel that's imaged. And it's not a very sophisticated approach that needs to be taken to realize that this is a highly abnormal vessel. And it's abnormal because the flow has remodeled that vessel. There's positive remodeling or outward remodeling of the vessel, not an inward remodeling that leads to the stenosis or narrowing. So this is a different disease manifestation, and it too evolves over time. There's a lot of discussion in recent years about this, although that we looked at this 20 years ago in terms of calcifications, that for many years, this was considered not a form of Icad because it doesn't cause a stenosis. But as has been demonstrated by many recent groups, it is Icad. It's just it exists at a place where it doesn't cause focal stenosis. Excuse me. Most commonly, we see this in the distal vertebrals and the carotid siphons. So overall, perhaps we've been a little too selective and overly focused on looking for the focal stenosis. And some people ask, well, why do we do this? We do this because it's easy to define patients this way. This is the way we write trials and grants. It's easy to identify those patients with the most severe disease. But what we don't consider as well is the temporal profile. So the temporal profile or the time changes are important. Of course, this is an acute on chronic disorder. It presents with acute stroke, but it's an underlying or chronic disorder. We also don't know which stroke it is. You heard in the last talk the point about a history of stroke. Believe it or not, most of the trials have not considered where that stroke occurs. So the history of stroke may be an old lacune, contralateral lesion. But what we really mean is stroke in the territory. And we don't ascertain that well based on clinical events, but imaging can tell us that. So overall, we wind up with blanket conclusions in the field that stenting is bad and that it hasn't shown us anything. And we have to be very, very careful about this because at the same time, we've heard that, we talk about best medical therapy. Optimal medical therapy is what I like to call it. It's the best we've been able to demonstrate in the trials. For many years after Sampras, best medical therapy was dual antiplatelet therapy for 90 days. All of a sudden that changed. And now as we're doing the Captiva and the Captiva MRI studies in the United States, now we're treating people with 1 year of dual antiplatelet therapy in comparison to other therapies. Why? Because we all of a sudden decided that actually that there was nothing magical about 90 days of dual antiplatelet therapy. And the worst conclusion that we could make is that there's an unproven need to treat these Icad patients or see them in follow-up. There's an absolute imperative to see these patients because they will come back no matter what with recurrent events or cognitive impairment. So one of the difficulties is that there's a lot of variables. There's a lot of things that we can focus on. And of course, with Icad, we have more time. So it makes it much more difficult in terms of the decision-making, as I mentioned. There's too many things to look at. Plaque growth, and now with imaging, there's many different variables, as I'll show you. And there are multiple mechanisms of disease. There are myriad mechanisms, and this is why we called the study Myriad many years ago when we started to write the Myriad study that I was one of the PIs with Jose Romano and Sham Prabhakaran, where we looked at imaging predictors of recurrent events. And we tried to figure out perhaps which was the most potent mechanism of recurrent stroke. Well, what we found was is that the recurrence of early stroke on imaging surveillance is much more frequent than we ever thought, much more frequent than ascertained by clinical events. That was the main finding. It was very difficult to find which was the most important mechanism of stroke in Icad. And that's because they run together. The mechanisms go together. When you have low flow in the downstream territory, you're more likely to lodge embolic events. And a lot of these, there are a lot of combinations of these mechanisms that go together. The other problem that we had is, again, with the definitions, in terms of how we define what's normal versus abnormal, what we call dichotomous definitions. When we look at flow velocities in a stenosis, what defines normal versus abnormal? Even with computational fluid dynamics and advanced methods, the fractional flow reserve is 0.8, the right threshold. Tmax perfusion that I showed you a few minutes ago, what is normal versus abnormal? A lot of these definitions are not very well understood at all. As I mentioned earlier, endpoints matter, whether they're clinical stroke events. One of the problems, as mentioned in the Basler studies, was in general, when patients present with recurrent TIAs, after they come back reporting recurrent TIAs on many occasions, then they may decide, or the providers may decide that that they're a failure of therapy, and then we have to go on to a different treatment approach. But the role of TIAs is not well understood. It may be a manifestation that such patients do better because they have ischemic preconditioning that occurs. And as well, as I mentioned, this history of stroke issue. Stroke is not a uniform disease. There are a lot of subtypes of stroke, and we have to be careful when we think about whether the stroke is in the territory because of the Icad or it's another type of stroke. So they're not all the same. So cognition, there's a lot more to think about as a provider, as a stroke care provider in general. And recent trials have shown us that even very crude neurocognitive evaluations, such as the MoCA, are important in predicting who has perfusion failure and the likelihood or a high likelihood of recurrent stroke. We looked at this in Sampras, where the MoCA, in terms of the degree of cognitive impairment, ran together with a perfusion abnormality. And those people at baseline were more likely to have recurrent stroke. And people often look at this curve and say, well, why did the curves come together at the end? And that's because it only looks at the patients that were retained in the study, because everybody that had a stroke dropped right off that red curve and were no longer included. So they either had strokes or died or even worse cognitive impairment. So it's important to consider how we see people over time. So this has been a common theme that comes up again and again. And for more than 25 years that I've been in the stroke field, we've often talked about failure of prevention. And this is a funny definition or a funny term because it's a relative failure. I don't know anybody that's ever assured anybody that we have a cure for all stroke, which means 100% prevention, that we can guarantee any patients that they're never going to have a stroke. So when we put a patient on therapy and they have a recurrent stroke, is that truly a failure? Many years ago, before anybody did anything for dyslipidemia or glucose management or other risk factors, we had antithrombotic therapies. And when a patient came back to us and they failed or had a recurrent event on one antithrombotic therapy, the question was, what was next on the menu of antithrombotics? What next agent should we use? And we just moved from one to the next without really understanding the mechanism of why they failed. I think that approach doesn't make very much sense. There's multiple approaches that need to be taken from a stroke prevention standpoint. And then we come back to this issue about the failure of endovascular approaches and the failure of angioplasty and stenting, which I'll expand upon more in a moment. But in general, we have to think about how we consider failure. This is a relative measure. If you do intervention, if you stent a patient and they have a restenosis, but no clinical events and follow-up, is that truly a failure? I would say from a clinical standpoint, obviously no. So how do we use the tools or the new toys that we have available? And there's a lot. We have a lot of different imaging approaches. We do even have the genomics and expressomics, where we have just started a biobank of genomic and proteomic analyses of patients with Icad on a multi-center basis in the United States with NIH funding. What do we do about the resistance testing of the patient's response to various antithrombotic strategies? This has been an open question and a very confusing one to providers recently. Platelet responsiveness and whether patients are actually responding to the medications that we put them on. Whether they're responding to the blood pressure medications. It's one thing to prescribe medications. It's another thing if the patient's actually taking it. And a third, if they actually respond based on something we can measure. Even beyond that, and all the things we can acquire in terms of imaging and serology, even something as simple as blood pressure. We have too much data nowadays. We're swamped with data and we don't even know how to analyze it very easily. So there is this promise of AI and data mining and what we can do in large scale data analytics. I don't think we're necessarily ready to do this in Icad. We will have a lot of data and we have to think about all these variables. We definitely don't have a limitation in data available anymore. So what can we do in terms of future studies? Well, we can look at the paradigms that we have, either observational studies or selective therapeutic studies. But when we do focus studies, selective studies, we have limited results. And then we always go back to the variables that we described in the earlier talks based on selection criteria, severity of disease, age, and other variables. And we never take a giant step back to think about how we put it all together, because that's how we practice on a daily basis in terms of thinking about all these variables. So the modern methods available to study Icad include now serology, blood sampling, genomics. We don't know what to do with it yet. Routinely available imaging is now very useful. We don't need very fancy imaging methods. We use CTA and we use perfusion and MRI, but we can do a tremendous amount with CTA and CT perfusion and not even angiography. There's a lot that we have in terms of measuring vital signs such as blood pressure and heart rate and even physical activity. But what's important is to be able to characterize patients at different stages of the disease in the acute or chronic phase, and actually to see these people back before they have a recurrent stroke. So there's been a lot of discussion about this, building upon this idea of failure and failure perhaps of studies, which I'll address in a moment from our very recent data. We do need to rethink trial design because, as I've said for a long time, the only people that have failed have been us as trialists. We take great pride in calling ourselves trialists, but we're responsible for the trial design. And when something fails, perhaps we should be to blame because we haven't designed the trials appropriately to demonstrate what we need to show. Now, it is difficult. It's not easy to study everything at once, and we have to think about how we do that. So in terms of recent data, this is a particularly interesting example. So CASIS, as you know, was started actually a very long time ago, many years ago now. It was only recently published. I worked with a group over the years of the study, and this was published only in the last couple of months. And it was very carefully done. And in the end, all we ever think about from a trial standpoint is the final result. And the data was described earlier, and it's shown here. By comparison, especially done in China, it's not a very, very large study compared to other studies. But the impact of CASIS was in the media and in general was very different than the impression I got as being one of the authors on the study. The impact, the media picked this up and said that stenting hit a wall, that there was no utility, that it was a negative trial for stenting. I disagree with that. I strongly disagree with that, because when you look at those event rates are a fraction of what's been quoted in Sampras and prior stenting studies. Now, the difficulty is that when you compare the medical to the stenting arms, there's not much of a difference. That's good news in terms of the fact that both rates are lower. So those historical rates are different historically than the much higher rates that we heard from Sampras and other studies over the years. So I think there have been improvements in stenting. The challenge now is how to demonstrate which patients are most in need of endovascular therapy. So we have a lot of data, and we have more trials, and we will have more trials that are coming online very soon. I think that there has been a revival. We went through at least 10 years of a détente, or a very quiet period in Icad treatment. After Sampras, there was very little interest for a number of years. And it took a while. It took almost 10 years for people to get interested again and to realize that these patients are coming back again and again, and the diagnostic methods have improved, and we need to do something about this. So how do we really study these patients is an open question. It's not that easy, because in the United States, at least, we're told you should never be stenting a patient unless they've had 2 strokes, are admitted with a recent stroke, you've waited 7 days, they're failing medical therapy, and they're at high risk for another event. What happens is that these patients fail at day 5, at day 6. Last spring, I had 2 patients within a couple of weeks of each other that both died on day 6. And we were kicking ourselves, because the question was, why didn't we do something earlier? And this has been a big issue. Separate from that, we have this issue of rescue stenting that was mentioned earlier, rescue stenting after thrombectomy. What do you do? And this very commonly occurs in Asia, after a thrombectomy, where then you find an underlying stenosis. In the United States, we get very scared because we're told that stenting should not be done. And then, unfortunately, the same turn of events happens as I described. These patients reocclude and have a bad outcome. So there are studies coming online. There are a lot of different ways to study this. We do have very common approaches that can be used that explore all these variables. So I'm going to end with a couple of thoughts. That precision medicine is an ideal. Icad is an ideal platform or situation to employ precision medicine. It's important for us to study the most common cause of stroke worldwide, not just in Asia, but around the world. Understand that stenosis is just one manifestation of this disease. It manifests, as I showed you, differently, with diffuse disease, with calcifications or mineralization, and not always the same way. And that we have to be able to understand the mechanisms in individual patients and try and tailor our therapies for those mechanisms of recurrence. So we can do selective studies, but we can also study a lot of these things in many different settings. So the good news is that there's a lot to study. There's a tremendous amount and an impetus or an encouragement to study Icad. It's ripe, as I hope I've demonstrated to you, for precision medicine. And there are a lot of different ways to study this, particularly using imaging approaches. Thank you.